Okay, we're going to get started. It's 1:30. My name is Mitch Horowitz from Duke University, and I have the honor of chairing this session, which I'm really excited about for a number of reasons. The most exciting is that we're all three here, we're all COVID-free, and we're all up on the stage, so we're going to be able to have a panel discussion at the end. We're going to leave time for that, which I hope we'll be presenting some stimulating data. The other reason why this is a really fun session is that most of this data is unpublished, it's new, and although I'm biased, I think it's one of the most exciting areas of not just cord blood transplantation, but stem cell transplantation in general, even cellular therapy. I'll even go that far because I spent the early part of my career in a basic stem cell laboratory and gene therapy laboratory. And while this is now the mid to late 90s, there were techniques to expand embryonic stem cells. There was no viable technique to culture and expand and preserve hematopoietic stem cells. It seemed to be almost the holy grail of stem cell biology. And now we have multiple technologies that can seemingly preserve, if not expand, pluripotent hematopoietic stem cells. And you're going to hear about two that have already reached the clinic and one that's just beginning in our third talk. I'm going to start by updating you on omidubicel development. Many of you are familiar with the phase 3 study that was published in 21, but there are a number of secondary endpoints which I'll talk about that have been mined and evaluated and on the verge of being published. Sandra Cohen from Montreal is going to talk about UM171, another very promising cord blood expansion technology, and she's going to present new data on how it's performing compared to standard cord blood transplantation. And then Filippo Milano from the Hutch is going to talk about another expansion strategy. If you thought double cord blood transplant was crazy, wait till you hear about what he's going to talk about. Multiple cord blood expansion processes. So I'll start the discussion with the omidubicel development. This is something we've been working on with Gamidacel, which is who has been developing this now for over 10 years. I began working with them 13 years ago and have some exciting things to talk about. These are my disclosures. I get research funding from Gamidacel and work on DSMBs and advisory boards from a few other companies. So I'll start with reviewing the results of the omidubicel phase 3 study. That's published, and it'll form the basis for the secondary endpoints, which I'll discuss on the third and fourth points, the immune recovery sub-study that was performed with the phase 3 study, as well as health-related quality of life. But I'll start talking about a long-term follow-up study of the entire omidubicel experience. And I'll start by reviewing what omidubicel is. Omidubicel is an expanded cord blood product making use of nicotinamide, which is a master regulator of NAD-related signaling. It enhances cellular functionality and improves homing and retention of stem cells to both the bone marrow and lymphoid tissue. And the biology and what nicotinamide does is still a little bit unclear. We know it has lots and lots of functions, and the preclinical work suggests that it preserves stemness when you take a stem cell outside the body. It downregulates signaling pathways that are typically activated upon removal of stem cells from the bone marrow, reduces cellular stress, inhibits differentiation. All those things sort of add up to optimizing a culture system that includes stem cell active cytokines that have been used in the culture system for many years. Omidubicel production and manufacturing starts by the transplant center selecting a single cord blood unit that meets the specifications that Gamidacel has outlined in their development of this product. That cord blood unit is selected and sent directly from the cord blood bank to the manufacturing facility. There, the unit is separated into CD133 positive progenitor, stem and progenitor cell fraction, as well as a non-selected T cell containing fraction. The expanded fraction is cultured for 3 weeks, harvested and cryopreserved, and along with the cryopreserved non-cultured fraction is sent to the transplant center. Omidubicel was tested in a registration trial, a multi-center randomized study. 125 patients were randomized to either Omidubicel or standard cord blood transplant, with the primary endpoint being the time to neutrophil engraftment. Secondary endpoints, platelet engraftment, infections, and hospitalizations. All of these data have been published and reported before, but the additional endpoints I'll talk about today. And just to review, these were the data which were what was expected from the pilot and phase 2 studies of Omidubicel. This shown here is the as-treated population, 52 and 58 patients respectively. The median time to neutrophil recovery was 10 days for Omidubicel and 20 days for standard double or single cord blood transplantation, which is reflective of the literature. And the time to platelet recovery was also quicker, 37 versus 50 days for the control. Now, we sort of expected this finding on the left. The incidence of grade 2 and 3 severe bacterial or fungal infections was lower, probably and intuitively related to the rapid neutrophil recovery. This finding, fewer viral infections, was unexpected and prompted a search to find and better understand the mechanism of that, and I'm going to talk about that shortly. So before I talk about those secondary endpoints, I'd like to acknowledge Chen Lin, who's a very talented hematology fellow at Duke, who's working with me and has compiled a very thorough review of the entire clinical experience of Omidubicel, comprised of 105 patients. So when you look at the 5 studies that have been performed, 3 of which were hematologic malignancy studies, 2 led by our pediatric colleagues at Duke targeting sickle cell disease. There were 212 patients screened for these studies. Some never made it to transplant. Some were randomized on the phase 3 study to standard cord blood transplantation. And when it was all said and done, we have 105 patients that engrafted with Omidubicel. And this forms the basis for this long-term follow-up study that was run by Gamida for the separate study for the early phase studies, and then was part of the phase 3 study to continue to follow these patients long-term. And again, multi-center, multinational study, 105 patients that were engrafted. And we really wanted to know how this graft was performing over the years, particularly and most importantly, hematopoiesis. How did this ex vivo expanded stem cell product, 3 weeks outside the body, how did it perform? And we were gratified to see that with some patients now over 10 years follow-up, there was no signs that the graft was failing late. This is a patient, this is the very first patient to receive Omidubicel at Duke, now 12 years out. So white count, hemoglobin, platelet count, all preserved over the years. There were graft failures that were reported in the initial publications. These occurred in the first year post-transplant. There were no additional graft failures beyond those that were published and reported and observed early on. So we're going to talk more about this in the third part of my talk, but we did have a sub-study and in the phase 3, and we're looking locally in the phase 2 on quantitative T-cell lymphoid subset recovery. And we see that we get rapid T-cell recovery. In fact, we'll compare that in the phase 3 to standard cord blood, but we see progressive T-cell subset recovery that is preserved over the years. We are continuing to monitor for late infections, but have not seen any signal for late infections. So the quantitative studies here seem to represent also T-cell diversity that's maintained over the years of follow-up. Now here are the overall and disease-free survival curves for the Omidubicel engrafted patients. It's a subset of all the patients that were transplanted, 62% at 3 years, disease-free survival 54%. And this is the heme malignancy subset of 98 patients of the 105. And the chronic GVHD incidence, most of which was mild, was 36.7% at 3 years, and the relapse rate 24% in a very heterogeneous group of patients with heme malignancies. Now, the other important adverse event of interest would be secondary donor-derived malignancies. Dr. Glickman spoke of that earlier in the earlier session. This is a very obviously troubling event that could occur. And we saw one case of this in the expanded cord blood experience. And the patient, this developed 40 months following transplant, fortunately rescued with a haploidentical transplant. Now, you know, it's one of 105. And interestingly, we saw another case of this in the phase 3 study, this time in the control arm. So if you scan the literature, and Dr. Glickman alluded to this earlier, this is potentially something that's underreported. When you're monitoring patients with leukemia who relapse, you can understand how there's the possibility that that relapse could be donor-derived, and the center missed it and just assumed, understandably, knowing the chances that this was host-derived, but it could be donor-derived. When you monitor patients very closely, continue to do chimerism long-term as part of the study, you're going to pick it up. So I believe we don't really know what the baseline rate of donor-derived malignancies are. There's some very interesting recently published papers showing driver-type mutations occurring prenatally. JAK2 and mutations in particular have been postulated to occur prenatally. So what you do with these units, these stem cells, by, in an unnatural way, transplanting them into a myeloablated marrow could potentially increase that risk. So this has to be followed. We saw 2 cases of PTLD in the experience as well, somewhat expected. So Omidubicel-derived hematopoiesis is durable for now over 10 years of follow-up. Immune function appears to be robust late. No late cases of secondary graft failure. A 1% risk, at least so far, of a donor-derived MDS was observed in this population. So now I want to talk about immune reconstitution, and this was of particular interest when we saw the reduction in viral infections in our population compared to controls. Paul Sobolitz from Pittsburgh has been leading this investigation, as well as Gamidacel, in particular Dima Yakubov, who's done a lot of work in the samples that were retained. Here's the original study design, and a small subset of 17 Omidubicel recipients and 20 cord blood recipients we were able to get samples for a very in-depth immune recovery study. I should remind you, and I'm not going to go into too much detail, but because of the manufacturing technique, the recipients of Omidubicel get about 1/3 of the T cells that are contained in the unit. So this is the overall experience of the 108 as treated patients, 3 × 10⁶ per kilo T cells per kilo versus 5.3. And in the sub-study of 37 patients, 1.8 versus 6. So they're starting off with fewer T cells. We designed the study such that samples were collected for immunophenotyping by flow cytometry and quantitation at these days post-transplant, multiple dates. And then we also retained samples for NGS T-cell receptor diversity studies at day 0, 100, 180, and 365. Now, what we observed quantitatively was also unexpected at these very early time points. And this is really the sort of the crystallization of the differences that we found that are highlighted here. At day 7, we saw a higher number, albeit low number, of CD4 and CD8 positive T cells. And this difference was also seen at day 14. Most of the subsequent time points, there was no difference in quantitative T cell subset observations. But these early time points, which correlates a little bit with the early viral infections, that's seen in the first 100 days. So this is potentially some hint as to why we're seeing fewer viral infections. Flow cytometry-based characterization of recent thymic immigrants also suggested at day 14 that there were more TREX, recent thymic immigrants, not TREX. At days 14, CD4 positive RTEs, CD8 positive in total at days 14 and days 365. So this was the flow-based analysis of recent thymic immigrants. We did not see any significant difference in this subset by looking at NGS of the T cell receptor. In these 4 different methods of comparing T cell receptor diversity, we did not resolve any significant differences between the Omidubicel recipients or the standard cord blood transplant recipients. So for the immune recovery component of the study, more rapid early T cell recovery of CD4 and CD8 positive T cells, a higher number of recent thymic immigrants as measured by flow cytometry in the peripheral blood at 1 year in the Omidubicel recipients, no observable difference in T cell receptor diversity. So there is a hint here that maybe there's something interesting, and I feel like there's something we're still missing in the difference of the two that would help us understand the mechanism by which we observe the reduced viral infections. I'm going to end by talking about another sub-study done by Chen Lin again, this time mentored by Tony Sung, a colleague of mine at Duke. And this took advantage of the health-related quality of life data that was collected by Gamida and as part of the phase 3 study. Again, in this sub-study, we were able to get forms and data from 37 Omidubicel recipients and 38 standard cord blood transplant recipients. These surveys were administered at baseline at day 42, 100, 180, and 365. There were 2 validated measures of health-related quality of life, the FACT-BMT and the EQ-5D3L. We had 75 total in this study. The baseline characteristics were well matched. You see there was no significant difference in the subset of patients that provided data with respect to demographics, clinical measures, disease risk index, HCTCI, well matched. The subset does reflect, for the most part, the primary observations of the study, which is that there was a shorter time to neutrophil recovery, 10 versus 20 days, which almost mirrors what we saw in the whole group. Fewer viral infections, 5.4 versus 31% in the first of severe viral infections, and a shorter time in the hospital. We did not observe the difference that we observed in the larger group in grade 2-3 bacterial infections, and the rest of the measures were the same. So I'm going to go through the results in the remaining few minutes of the FACT-BMT and the EQ-5D3L. The point of this slide on the right shows you that one of the main questions of the BMT subscale, question number 4, the side effects of the treatment are worse than I had imagined. And there was a statistically significant difference in the Omidubicel recipients with the answer being either very much, quite a bit, or somewhat worse than I had imagined. So just look at this is at baseline and last assessment, 20 and 11% versus 19 and 26%. So more patients who received standard cord blood felt that the treatment and the transplant was worse than expected. Now here are the AUCs and the curves of the FACT-G domain score. This is a 24-question survey. What's called minimal clinically important difference, MCID, is defined as 2 points, and this difference was observed at day 180 and 365 for physical well-being, and that difference was also observed early on for functional well-being. You can see when you look at the area under the curve for both cohorts, there was a statistically significant difference for physical well-being and functional well-being. Note that in these two domains, the drop-off at day 42, which one would expect in patients going through transplant, is less severe for physical well-being and functional well-being, probably because they get out of the hospital sooner, they engraft sooner, and they just feel better sooner. Here's the total health-related quality of life scores. In this case, for the total score, 7-point difference is minimally clinically important, and that was observed at day 42 for the whole entire VACT-BMT survey, day 100 and day 180 and day 365. All of those time points, there was as defined by the instrument, a clinically significant difference. The same with the EQ5D3L. This is a very simple 5-question survey, significant difference at day 100 and day 180. So in summary, in addition to the known clinical benefits, omidubicel demonstrates improvement in patient-reported quality of life. The most significant improvements were in physical and functional well-being, as well as the overall health-related quality of life. There was faster recovery of physical well-being and compared to standard cord blood transplantation. And these reductions, improvements in quality of life may be related to the reduction in infectious complications, and we're evaluating this further. So I'm going to conclude by stating that omidubicel, which is an expanded hematopoietic stem cell graft, provides durable and robust multi-lineage hematopoiesis for now over 10 years of follow-up. There seems to be more rapid immune recovery, resulting in fewer infections, and improves the post-transplant quality of life compared to standard cord blood transplantation. Now, the biologic licensing application has been submitted to the US FDA. I don't know the timing for the European agency, and we're hopeful that it will be approved and available commercially by January or February of 23. So I think that this should be considered a new standard of care for alternative donor transplantation, and I hope that one day we can see data comparing this to other types of transplants, because for all of us who are cord blood aficionados, we can only be enthusiastic about this graft source for our patients. So thanks for your attention. The next speaker will be Sandra Cohen from Montreal.
Thank you very much. So my talk also is going to be a bit of a plea for the cord blood community. You know, we have to save cord blood. I think it's a great stem cell source, and we just need to show everybody else that it's a great stem cell source. These are my disclosures. So I don't need to explain these graphs, but essentially we all know that the use of cord blood has gone down in the past few years. And so why is cord blood still important? Well, we know that approximately 1/3 of patients will not have an HLA identical donor, and to those who believe that haplo is the answer, well, 10 to 15% of patients will not have haploidentical donors. They don't get medical clearance, so they have HLA antibodies, or there's what I call the less desirable haplodonor, older donors, which have been associated with worse overall survival. And so there are many advantages of cord blood, and we all know, but I'll just repeat it again. Those are low risk of relapse, low risk of chronic GVHD, and it is rapidly available in a time of pandemic when it's hard sometimes to get, a matched unrelated donor graft to you. A cord blood can be available within a week. So, to the transplant community, I say that haploidentical and mismatched unrelated donors cannot and will not solve all our donor issues. And cord blood is probably more desirable in certain situations when the transplant is urgent or there's a high risk of relapse. So how do we fix this problem? So how do we convince transplanters that cord blood is really good? So there are several things. First of all, we all know that cord blood selection is a bit more complicated. Haplo is much easier, but now there have been publications suggesting how you should select it. There's the low cell dose issue, prolonged neutropenia, prolonged admission to the hospital, increased risk of infections, and the increased risk of non-relapse mortality. And finally, some people say there's a slower immune reconstitution, but I will argue that the risk of viral infections after a haplo compared to a cord are very similar. And if you're doing an unrelated donor transplant with ATG, which has become the standard in many places, the risk of viral infection is really very similar. So we're left with the non-relapse mortality. So how do we fix this? So the cell dose issue, that's pretty obvious. We need to fix that. And there's another point that I'd like to make, and I know it's very controversial, but it's the HLA match. So I believe that if we better HLA match the cords, and the reason for that is because it's been shown by the CIBMTR that each HLA mismatch will increase transplant-related mortality by 5 to 10%. I'm not saying we should do 8 out of 8, and I know some people will say, well, it's overall survival doesn't change. But my point is, the reason why haplo is so popular is because non-relapse mortality is low, it's easy, and I think transplanters prefer their patients relapsing than dying of non-relapse mortality. So I believe that if we increase the cell dose, we can access smaller cords that are better HLA match and therefore reduce non-relapse mortality. So I'm going to concentrate on stem cell expansion, and what should expansion ensure? Obviously, you want prompt neutrophil engraftment, but it's also important to look at all the different aspects of hematopoietic reconstitutions, T cells, CD4 count, and as was mentioned, we, with our procedure, lose approximately 50% of the T cells. So it's very important to look at T cell reconstitution. You have to look at B cells, NK cells, platelet, long-term engraftment, and most important, you don't want to lose cord blood's advantages of low risk of chronic GVHD and the low risk of relapse. So I'm going to be discussing UM171, which is a small molecule that was discovered at the University of Montreal by Dr. Sauvageau and Marinier, which enhances hematopoietic stem cell self-renewal. Here's the mechanism of action. It's been published, so I won't go through explaining. So UM171 is an expansion that takes 7 days. It's a single cord blood transplant. The cells are CD34 selected. The CD34 positive cells are placed into culture with UM171 and growth factors. And then you have the CD34 negative portion, which is frozen again after the CD34 selection, and are thawed and infused to the patient at the time of transplant. So the goals of UM171 cord blood expansion was really to lower the non-relapse mortality of cord blood. We wanted to shorten the duration of neutropenia, and we wanted to better HLA match our cords. We wanted to go from our standard 5 out of 8 to a 6 out of 8. And we didn't want to lose cord blood's advantages of low risk of relapse and low risk of chronic GVHD. So this is a scatter plot of all the cord bloods in the EMA Quebec cord blood bank. And it's adjusted for a 70-kilogram patient, and it shows with the TNC dose and the CD34 dose that with the minimal cell dose criteria we have now, we can only access 5% of the cords in the bank. And therefore, we're selecting poorly HLA matched cords. With expansion, so with UM171, we can now access 50% of the cords in the bank. So therefore, we're able to access smaller, better HLA matched cords. And this data was reproduced by the NMDP. So we initiated in 2016 a phase 1/2 trial for patients lacking an HLA identical donor with UM171 cord blood transplant. 27 patients were recruited. The initial patients received a double cord as a safety procedure. And then 23 patients were enrolled on the single UM171 cord blood transplant part of the trial. The endpoints were feasibility, safety, and we wanted to determine the smallest cord blood that could achieve prompt engraftment after expansion. So I'm going to summarize really quickly that it's a 7-day culture. There was a 35-fold expansion of CD34 cells. Patients received a median of 2.88 million CD34 per kilo and a median 2.7 million CD3 per kilo. And there was no contamination in the culture. There were some very high-risk patients that were recruited to the study. Median age was 45. There were only adults on this trial. Almost a quarter of the patients had failed a previous allogeneic transplant, and 2 patients had failed a previous cord blood transplant. And there were several patients that had acute leukemia or aggressive lymphoma, not in remission or not chemosensitive. So we achieved our first goal of better HLA matching the patients because more than 80% of the patients got a 6 out of 8 match or better, as opposed to our standard at the same institution where 80% of our patients get 5 out of 8s. So time to neutrophil engraftment was 18 days, but time to 100 neutrophils was 9 days. And the reason I mentioned the 100 neutrophils is because we believe the patients derive clinical benefit from this because the majority of patients resolved their fever at day 7, and we think they benefited from the recovery of 100 neutrophils. There was the risk of severe acute GVHD, 3 to 4 was 10%, and there was no steroid refractory acute GVHD. There was no moderate to severe chronic GVHD, and the median time to discontinuation of immunosuppressive therapy was 6 months. All patients were off immunosuppressive therapy by 13 months. Transplant-related mortality was low at 4.5%, and the risk of relapse was approximately 35%, which is respectable, I believe, in such a high-risk patient population. In terms of viral infections, there were no severe or life-threatening viral infections. The risk of CMV reactivation was 50% in patients at risk, and patients did not receive letermovir prophylaxis, and there was no PTLD. So there was prompt lymphoid reconstitution, and I'm just going to concentrate on the CD4 count. Median CD4 count at day 100 was 200, at 6 months 300, and at 12 months was 400. And so I decided to compare to our same institution patients transplanted with unrelated donor transplants, and our standard is to give ATG. And as you can see, our CD4 count recovery was faster after our UM171 cord compared to our matched unrelateds who received ATG. I also decided to compare to our in-house haplo-PT-Cy patients, and CD4 recovery appeared to be more rapid after a UM171 cord compared to a haplo-PT-Cy transplant at the same institution. So we also decided to compare the immune reconstitution of our UM171 cord bloods to our conventional cord bloods transplant at the same institution. And we observed that there were less severe infectious complications in our UM171 cord bloods. As well, there was greater TCR diversity at 6 to 12 months after a UM171 cord blood transplant. And here you have the survival data with now the median follow-up almost up to 5 years. As you can see, at 2 years, overall survival, progression-free survival, and CRFS are at 73%, and GRFS at 2 years is at 64%. So in conclusion with this study, we believe it's feasible. We believe we can safely transplant smaller, better HLA-matched cord bloods. Transplant-related mortality appears to be low, and the advantages of cord blood appear to be preserved. So how do we confirm these results? So yes, we only have 22 patients. Obviously, it would be nice to have a larger phase 2 trial, a randomized phase 3 trial. However, we all know that's very costly. So we decided to start with a match pair analysis. So we approached the CIBMTR, and we decided to do a CIBMTR match pair analysis. And the objectives were to compare our 22 single UM171 cord blood transplants to a conventional cord blood transplant. But we also thought that we needed to compare it to standard of care, because if you show that you're better than a conventional cord blood transplant, how much are you going to be able to convince the transplant community that this is worthwhile? So we decided also to compare to matched unrelated donors, 8 out of 8, who received peripheral blood. So the CIBMTR identified matched participants with direct matching or propensity score matching. Inclusion criteria were as follows. They had to be transplanted in a US or a Canadian center. The transplant occurred between 2014 and 2019 to correspond to similar years as our transplants. Adult patients between the ages of 18 and 65, a performance status of 70 or above, an ablative conditioning regimen as defined by the CIBMTR. For the cord blood controls, they could be single or double. They had to be matched minimum 4 out of 6. They had to receive a calcineurin inhibitor with mycophenolate, and ATG was not permitted. And for the matched unrelated donor control arm, they had to receive peripheral blood, be matched 8 out of 8, receive a calcineurin inhibitor with methotrexate or mycophenolate, but ATG was allowed. So the endpoints were for primary non-relapse mortality, progression-free survival, GRFS, overall survival, and secondary endpoints were relapse, acute GVHD, chronic GVHD, engraftment, and the risk of graft failure. Variables that were used for direct matching were if they had received this was their first allogeneic transplant or second allogeneic transplant, the disease, obviously, the refined disease risk index if it was a first allo, and the disease for second allo was either intermediate or advanced. Variables that were used for propensity score matching were patient age, comorbidity index, and KPS. And we attempted to identify 4 matches in the CIBMTR database for each UM171 patient. So here are the results. So they identified 137 controls, so 67 cord blood controls out of a possible 88 that we wanted, and 70 peripheral blood controls out of a possible 88. So here are the results of the univariate analysis comparing a conventional cord blood to a UM171 cord blood. I've color-coded it a little bit to make it easier. So in blue, I put what is equivalent. In yellow, results where UM appear to be better, and in green, where the controls appear to be better. So in terms of non-relapse mortality, UM171 had an advantage compared to conventional cord blood transplant. In terms of PFS, there was an advantage at 2 years. For overall survival, there was an advantage at 1 year. And for GRFS, there appeared to be an advantage for UM171 cord blood. In terms of relapse, there was no difference between the 2 groups. In terms of acute GVHD and chronic GVHD, the results were similar. In terms of neutrophil engraftment, the neutrophil engraftment was quicker with a UM171 cord, and also the 100% of the patients achieved neutrophil engraftment in the UM171 group versus 89% in the control group. In terms of platelet recovery, median time to platelet recovery was similar in both groups. However, at day 100, 95% of the patients in the UM1 group had platelet engraftment as opposed to 77% in the control group. There was no difference in graft failure. These are the hazard ratios for non-relapse mortality and GRFS. So as you can see, there is an advantage for UM171. And now the results for matched unrelated donor transplantation versus UM171 cord blood. So in terms of non-relapse mortality, there appeared to be somewhat of an advantage for UM171. For PFS at 2 years, there appeared to be an advantage. Overall survival was the same. There seemed to be an advantage for GRFS. No difference in terms of relapse. No difference in terms of grade 2 to 4 acute GVHD, but less grade 3 to 4 acute GVHD. Did I do any? No. Okay, so there was less grade 3 to 4 acute GVHD in the UM171 control group. There was less chronic GVHD, so what we expect. In terms of neutrophil recovery, it was more rapid after peripheral blood. However, at day 100, it was a similar percentage of patients that achieved neutrophil engraftment. Platelet recovery was more rapid after peripheral blood. However, at day 100, same percentage of platelet engraftment, and graft failure was similar. And here you have the hazard ratios for non-relapse mortality, so 0.06, and for GRFS, less than 0.01 between UM171 and matched unrelated donor peripheral blood. So here you have the cumulative incidence curves for UM171 cord blood versus matched unrelated donor peripheral blood. And the gray test, there is no significant difference. In green, you have UM171, and in blue, peripheral blood. So now you have progression-free survival of the UM171 cohort in green versus peripheral blood matched unrelated donor in blue. And this difference by log rank is statistically significant. And here you have the GRFS between peripheral blood, MUD, and UM171. And as you can see, there is a difference. So the goals of our initial study were to improve HLA match and to shorten the duration of neutropenia, to lower non-relapse mortality. So I believe we achieved that. However, with the caveat, this is a small number of patients. And the consequence of that, plus the fact that I believe we were able to maintain cord blood's advantages, the risk of GRFS appeared to be lower. However, we have to underline that this is only 22 patients, and we were unable to identify 4 controls for every patient. So in conclusion, UM171 cord blood expansion allows for transplantation of cord blood in a safer manner. TNC dose is no longer a limitation. It allows for better HLA match if so desired. Non-relapse mortality appears to be improved, and it appears to improve GRFS and PFS compared to matched unrelated donor transplantation peripheral blood. So for the future, there are several ongoing trials they're listed here. There's a match pair analysis with the EBMT that's coming. Should we perform more match pair analysis comparing haplo, mismatched unrelated? But obviously we need to confirm this in a larger trial, phase 2, ideally phase 3, but those are very costly. And so in conclusion, my plea to the cord blood transplant community, we really need to band together to convince everybody that this is still a very good graft source. And I will end here and acknowledge everybody who has contributed to all these trials. There have been many people, many institutions, so thank you very much.
Thank you, Sandra. And our next speaker will be Filippo Milano from the Fred Hutchinson Cancer Research Center.
Thank you, Mitch. Actually, we changed name now. It's Fred Hutchinson Cancer Center. We removed the research word from it. It's pretty new. Thank you so much for the invitation and giving me the chance of introducing to you this new approach that we have just started in Seattle as a new clinical trial. So I don't need to go through background very much because the previous speakers already talked about the advantage of cord blood transplant, but definitely we can say that when the expansion field was started, and we have Colleen actually is one of the pioneers starting in 2006, the main reason why we wanted to use expanded cord blood technology was for the low cell dose, for limiting the prolonged neutropenia, having a faster engraftment, and therefore reducing the non-relapse mortality and providing better outcomes for our patients. I think from the previous talk that you heard from Mitch and Sandra, I think we can say that we achieved that in terms of reducing that aspect of a limitation and drawback of cord blood transplant. I don't have time here to go through the entire chronology of how we arrived to this point, because again, a lot of merit goes to Colleen, starting the field in 2006, starting first with the fresh expanded, and then moving towards a cryopreserved off-the-shelf product. That said, in 2012, 2013, we decided to use this approach where we're going to use one single or double cord blood transplant unmanipulated along with a expanded, cryopreserved, not HLA-matched unit, which was deriving from a single cord blood unit. That's a very important aspect that will differentiate this trial from the other ones that I'm going to describe later on. As you can see here, we were giving a preparative regimen with 2 different approaches that I'm going to describe very soon. Cyclosporine and MMF were used as a GVHD prophylaxis, and patients were receiving chimerism analysis at different time points. We were lucky enough and fortunate to secure funding from the NHLBI to run a randomized study as a phase 2b randomized trial where we compare basically patient receiving a standard cord blood transplant, single or double, versus a single or double cord blood transplant plus the addition of the expanded cryopreserved non-HLA matched unit. As you can see here, the primary endpoint was time to engraftment, the second endpoints were platelet engraftment, incidence of infections, overall survival, no relapse mortality, and incidence severity of graft versus host disease. The two conditioning regimen we use, usually for younger patients up to 45 years of age, we use our standard high-dose TBI with 13.2 grade TBI, or we use the New York approach by Julia Parkett with intermediate for older patients with flu site Aoteva and 4 grade TBI. The first success of this study, I would say, is that we completed it. It's not easy to do a randomized study, and especially it's not easy to do a randomized study in the field of cord blood transplant. We aimed to enroll 160 patients. We achieved the goal. 80 was an intention to treat study, so 82 patients ended up in the expanded arm, receiving NLA-101 or dinalubicel, and 78 patients ended up in the conventional group. As you can see here, the benefit of running a randomized study allows us to not have bias and to have very matched cohort in both groups. The things that I would like to point out is that when we go for the cord blood units, the majority of patients still received a double cord blood transplant, plus or minus the expanded unit, but already 20% or 28% of patients received a single cord blood unit. This is a trend actually that we are seeing more and more at our institution, where we are doing more single cord blood transplant than we used to. The majority of patients received the high-intensity conditioning regimen, and we added the mid-intensity regimen only at the end. That's why there is this difference. About 18% and 23% of patients in both cohorts had minimal residual disease going into transplant. As I said, the primary endpoint of the study was neutrophil engraftment, and as you can see here, we failed to meet the primary endpoint with a time to engraftment that was 20 days in the conventional group versus 21 days in the group receiving the expanded product. The median CD4 cell dose that we was used for in the expanded group was 10 million per kilogram. Looking at the secondary endpoints, there was no difference for platelet engraftment, 38 days in the expanded group and 40 days in the group receiving conventional transplant. Going now to other secondary endpoint, overall survival was 70% at 2 years for the group receiving the expanded cells and 61% for the standard group. But that difference was not statistically significant. That translated also in disease-free survival was about 60% for both groups at 2 years. No difference was seen also in terms of no-relapse mortality, about 20% for both groups at 2 years, and relapse rate about 18% for the expanded group and 21% for the standard group. We do have data on acute GVHD showing no difference between the two groups in terms of grade 3 and 4 graft versus host disease. I don't have still the data on chronic GVHD, as the last patient has just finished the 2-year follow-up, so we're collecting those data, and hopefully we're going to present soon and submit this study for publication. So what are the lessons that we learned from this protocol? That an off-the-shelf non-HLA matched graft can be safely used in clinical practice and can lead to comparable clinical outcomes. It's important to point out that, as I said, this is a long journey starting in 2006. We designed this study in 2012 and started in 2013 and ended in 2018. So it's a 5-year span. And many things have changed in 5 years. In particular, what has changed is the ability for us to select better and better cord blood units, so that conventional cord blood actually is getting better in terms of engraftment. The historical 25 days that we were seeing with the previous trials, really it's kind of in the book. If you do a conventional cord blood transplant, you need to expect an engraftment around day 20, 21, more similar to what we see with bone marrow. But another thing that it's very important to point out is that while the study failed to meet the primary endpoint of improving time to engraftment, overall survival was excellent in both groups. And I point out especially for the conventional group, receiving the conventional cord blood transplant. This is not a single center study. 8 different institutions were participating, so that means that good outcomes can be achieved with cord blood transplant across different institutions using a standard approach. We were not satisfied. We did learn the lesson. Actually, more for you, Colleen, than for me. So, and since we saw that it was still very good outcomes with this approach, we say maybe we should spin around what we want to do. Instead of focusing on accelerated time to engraftment, trying to get something more out of this approach. What Colleen thought was that actually instead of pooling, or instead of using one unit and expand, not naturally match, then cryopreserve and use it off the shelf, Colleen has as Mitch said, the crazy idea to put together 6 to 8 cord blood units together, to pull the units together, expand for 14 days, and then cryopreserve and use as an off-the-shelf product. Now, this slide has been given me by Devera. It's important to say that using this approach, they both can go towards creating a product which is a CD34 product, and which is the one we use in the study that I'm going to show you very soon. But they also use this approach to generate NK, and a spoiler alert, I think Colleen is going to talk about this approach tomorrow during our session. We were reassured by the fact that the Vera Therapeutics actually used this approach in a launch study. Launch study is a 4-arm randomized study where basically they use this expanded product, pooled product, once again, in patients with de novo AML. 4-arm receiving induction or consolidation chemotherapy, plus low-dose cells, 100 million CD34, or chemotherapy plus 300 million CD34 cells, or standard chemotherapy, again, induction or consolidation, and followed by the infusion of 800 million cells, and compare that in randomized fashion to patients receiving chemotherapy alone. It's important to say that the patients were receiving the product at the end of the induction of the consolidation, that they basically 24, 36 hours after the end of chemotherapy. As you can see here, the study was designed for looking for a primary endpoint for seeing severe bacterial and fungal infection. The key secondary endpoints were the use of G-CSF, overall response rate, and evaluation of infection complications. There are also additional data that were collected. They were able to include 36 studies across the world, 25 in the United States, 7 in Australia, and 4 in South Korea. A study that started accruing in February 2018, and accruing very, very well in the after that, and they were able to enroll 146 patients of the 220 planned, but with 227 patients having data for evaluating a response assessment. The trial was concluded earlier because there was evidence of this trial not meeting the primary endpoint of infections, and therefore we're going to present the data on this subset of patients for the secondary endpoints. When we look at the characteristic of these patients with leukemia, you can see here that they were very similar except for the risk category, although it was a randomized study, ended up that patients with an unfavorable risk category based on the WHO classification, there was a high percentage of these patients among the one receiving a conventional approach, only chemotherapy, and also high rate was in patients receiving chemotherapy plus the 800 million dose. I forgot to mention that the study was designed in a way that patients could get multiple cycles, so going through induction, get the product, consolidation, several consolidation, you can get product at the first consolidation or second consolidation. And you can see here that they are very similar with the same rate of patients receiving 1 infusion, 2 infusion, or three infusions, both for the three group at different doses. The study included 184 infusion for 101 patient. There was some drug-related adverse event with infusion reactions, like fever and febrile neutropenia that was associated with some sort of CRS, but no new safety findings were identified, and the DSMB allowed always the trial to go on and never stopping the trial. I think that was very fascinating what Colleen and her group saw in this study, because when they compare the rate of complete response among the different groups, you can see here there was a significantly higher rate of complete response in the group receiving the expanded product compared to the patients receiving the standard of care. And in particular, this difference was more marked for patients receiving 300 million as a target dose compared to the standard of care. So in conclusion for this study, we can say that this was the first study of using an off-the-shelf product in the setting of de novo AML. It's a product that is available as an off-the-shelf product, cryopreserved, so readily available. And the safety profile was good, and it's without clear evidence of alloimmunization in any of these patients. And we can also speculate that this might have induced a potent autologous graft versus leukemia effect, like the one that is being seen in many studies in China with microtransplant, to overcome the immune escape that usually AML utilize to bring to a higher rate of complete response. So going back to the background and going back to what Sandra said at the end of her talk, I said she check mark about the achieving of a better engraftment, better GRFS, better non-relapse mortality. But the question is only that we want for expanded technology, or we want aiming for more? We do know that relapse rate is very low already with cord blood, but maybe we can enhance this GVL effect, especially in patients with a very high risk leukemia. And indeed, I can tell you that a similar approach has been taken by our colleague in Manchester in the UK, by Rob Wynn. I'm not going to go through the details of this study, and as a spoiler alert, we're going to have at 5 o'clock, we're going to have the literature review session where Dr. Politicos is going to talk about this paper specifically. But basically what Rob did in UK was to use granulocyte transfusion for pediatric patients with high-risk diseases, and with the idea of stimulating a response CD8 mediated, increasing the GVL effect. The paper was published in Blood Advances and showed very good outcomes for pediatric patients with very high-risk leukemia, actually with going into transplant with disease, not only with MRD. Another paper from that group is coming soon, showing a big benefit of this approach in patients with minimal residual disease. So we were very supported by the LAUNCH study data, and we were supported by the data coming from UK. So we decided to resurrect this study that where basically we're going to use the same approach using the AML study, but for transplantation. Differences between this study and the first one that I explained to you, Protocol 2603. First of all, we are not going to use double cord blood transplant anymore. We're going to use a single cord blood transplant, always, and with the addition of a single expanded non-HLA match unit, which derives from a pool donor. The conditioning regimen are going to be exactly the one we used before, same GVHD prophylaxis. We didn't know about the data regarding the 300 million looked a little bit better than the 800 million, so we did decide to use 800 million for this trial. The endpoints are, the primary endpoints are going to be graft failure and safety. Then we're going to look at engraftment, graft versus host disease, transplant mortality, overall survival, PFS, and infections rate. We are enrolling, as usual, patients with AML, ALL, MDS, and CML. And I would like to also acknowledge the similar approach we're using in another protocol, it's Protocol 4070, that we open at the Hutch, open for HIV patient. Many of you already know that actually I identified the first patient that might receive with this approach a CCR5 delta 32 negative unit pretty soon, and we hope that this approach will work as well for this patient. This protocol is actually funded by the NHLBI. So when we go back to cord blood selection, I'm pretty sure some of you is wondering what is going to be my selection for the single cord blood unit. What we are requiring right now are units that have a minimum of 2.5 and with the minimum recommended dose of 34, that has to be 1.7 times 10 to the 5th per kilogram. I already talked about the primary and secondary objective. Of course, we're going to see a bunch of exploratory objectives, but the other things that I want to say here is that in terms of the inclusion criteria, patient, of course, needs to have a good performance status, a good renal function, hepatic function, as for the other clinical trials. Once again, the high dose regimen will be used for younger patients, the mid-intensity more for the patient that are older or patient that cannot receive high-dose TBI. The usual exclusion criteria, of course, this patient, the history of HIV infection is worth for this trial, but not for the other one, of course. And I am happy to report that we enrolled finally our first patient, and that's the first time the report is data. Of course, is very preliminary. The patient got a transplant 3 months ago. Was a woman with a secondary AML after breast cancer, FLT3 positive. You can see here all the therapies she received. She was in CR2 at the time of transplant, 50 years old. With the weight of 57 kilograms. So definitely a patient that is on the smaller side compared to the average patient that we get in the United States. The HLA match, she received a graft that was 4 out of 6 and 6 out of 8 in total, with the 3.7 times 10 to the 7 TNC per kilogram. The patient actually started having counts around day 10 and officially engrafted at day 17 with the platelet recovery at day 27. The patient experienced a significant pre-engraftment syndrome, exactly like Rob Wynn is seeing in these patients in UK using the granulocyte infusion, which I forgot to say, but they're third party, so they are not coming from the patients. So they have the goal of stimulating the CD8 based on MHSC class 1. When we look at the chimerism, we were able to see mixed chimerism only at day 7, while the chimerism was already 100% single cord blood at the day at the other later time point. We have also day 14, which is not here, but it's only for research. But day 28 and day 100, she was one single unit. So this is pretty much the slide that I had before, the lessons that we learned from Protocol 26.3. But I would say that the only thing that I would like to add is that the goal is really now to focus on expansion technology. They are feasible at improve clinical outcomes, not only time to engraftment. We already learned that we can do that. Also, some of the outcomes presented are good for other endpoints like infections, but we can do better even for other outcomes such as relapse. That was my last slide. I need to thank Colleen, of course. Most of this work comes from her. The entire cord blood group. I have 2 clinical coordinators sitting in the audience that were coming with me in Miami, Laura and Jenna. Thank you for your work. Then clinical coordinator office, our unrelated office, the Vera Therapeutics for sharing the data about the launch trial, and of course our patients. Thank you.
So we're right on time, actually just 3 minutes over, which is great. We have plenty of time for discussion, so please feel free to approach the microphone, introduce yourself, and ask away. While you're doing that, I'm going to start things off. And this actually is a question for both Sandra and Filippo, because I think that when you, first of all, fantastic data, Sandra, and I could have predicted the favorable comparison to the CIBMTR control, mainly because your patient population was very high risk and the results are so outstanding. Some of these patients may be not even considered for transplant in some centers. So if you had to predict what the main component of the UM71 expansion technology provides to the recipient, is it the matching advantage? Is it the non-HPC component to the graft? You've talked about that in the past. What would you say? And I think this relates to the product that Colleen and Filippo studied in their expansion product. That key component of the expansion product.
So I'm not exactly sure which part, like maybe I was just lucky with my 22 patients, but I think As you know, UM171 expansion is not just an expansion of CD34 positive cells. It really changes graft composition, and I didn't really have time to talk about that, but there's a dendritic cell precursor expansion, there are common lymphoid progenitor expansion. So how much is that contributing? I'm not able to answer. However, I'm a firm believer in cord blood, and I won't repeat enough, low risk of relapse, low risk of chronic GVHD, and we just need to get rid of the bad stuff, which is the transplant-related mortality, and I think if we get rid of that, and you make the hospitalization a little bit shorter, I think it's really, you'll have only the advantages. But I do believe, now that I've done a second trial, and my second trial, which I didn't comment on at all, is it's very high-risk leukemia. So second transplants, refractory leukemia, and we purposely mismatched them at 5 out of 8. And when I compare my first and second trial, yes, they're sicker, the patients in the second trial. They were high risk in the first one, but they're even sicker in the second. There is more GVHD, and I think that when, cords, they can tolerate grade 2 to 4, but when they start getting into the 3 to 4 and the refractory GVHD, that's when you start getting problems. So I really think that maybe the sweet spot is 6 out of 8. I don't know exactly where that is, but I think the matching is important, and I think you need to recover neutrophils, promptly. Is that 10 days, which is great? Where does that number need to sit? I'm not sure.
So it's the whole package.
Yeah, sorry.
What about you?
Well, I want to just keep going on what Sandra was saying about cord blood transplant in general, and I think it's Mitch, you said that the omidubicel product should be the alternative of, for when we don't have a matched related or unrelated donor available. I think this is in an ideal world, is definitely the way it should go, because if we eliminate the problem of engraftment, of infections, we have a good immune reconstitution, people are not going to walk away from cord blood transplant. The problem is to understand how we can message these to the centers to make sure that they know the goodness of both your data and Sandra's data. With our approach, I'm not because I don't want to be positive, but just because I think we do need to find a niche for cord blood transplant. I do think that if we can carve our things around high-risk diseases, or like MRD, like we proved already that we can get results, I think maybe the people out there, they're going to start listening to us again. As I said to you, I really hope that the FDA process goes well and goes through, so that we have some product available that we can use with an indication for it. So I think that's what I would add to what Sandra has to say.
Thanks. Koen.
So, question and comment. You don't have to convince anybody here in the audience about the advantage of, so we're all talking to one another, and we're talking past one another. And in that sense, the approach that I have been using, and that already dates from 2003 from the Spanish, we get engraftment within 10 days we have 300 patients by now over, and multiple times published. Why would I give that up compared to any of these products? I wish I could give it up because it's far from perfect, but how do we move that forward? And then the other thing is, yes, we need to focus on the high-risk patients, but how do we define that? How do we do this study? Because there was already a randomized study with post-transplant Cy, and it was a negative study, and everybody chooses post-transplant Cy. Should we go to the older patients? All of cord blood is pediatrics, and everybody stops at age 60. That's not where the problem is. The patients with leukemia are over 60, and the bad risk patients in particular are over 60. Should we go there as an area of interest?
Well, I think, but I think we're saying similar things, though, because we do need to identify the population we want to go after. Yes, you're right. The majority of patients are older patients these days. The majority use of cord blood is in pediatric patients. But I do think that it comes down to understand where cord blood can perform well. Right now, it's very difficult to explain to the world outside. I do think that, actually, I had a question for Sandra regarding relapse, that I think it's something that we need to look after more and see whether or not really our data can be confirmed.
But so how would you, we've been saying that, sorry to put you on the spot, but
No,
we've
it's
been saying
fine.
that for 10 years.
Yeah.
How would you conduct the next study where we convince the field, not just ourselves, whether it's my approach or your approach or the third approach, which patient population would you focus on? And would you do a randomized study?
No.
Or would you choose patients?
We don't have the resources for a randomized study. I think one was done, it was not ideal.
Disaster.
Let's put it in that way. I think we had this discussion yesterday during an MDP meeting. I do think right now we need to stay humble. We need to focus on our strength, and we need to identify patients population that can be specific and go out there and doing that. You know, I say all the time that cord blood does very well for second transplant. It's one example. It's very good for MRD. You're going to see data from Juliet and others. So I think those are the things that we need to focus right now. But that's my opinion. You know that.
No, I mean, that's where we need to develop consensus, I think, as a group.
If I could just, one comment I would make, and this is, you know, I think we can't erase CTN 1101. That is dogma now. It wasn't a positive study or a negative study. It was, the primary endpoint was no different. But the take-home message, even in my book, was that haplotransplant's better for the older population. And I don't think we're ever going to reverse that, because that study didn't even complete accrual, yet it showed a sort of an edge to haplo. I think we have to focus on what we've been all hearing. We heard in the previous session with Junya Kanda's amazing results in again, a population of patients that we turn away in this country that are doing so well in Japan.
Yeah, actually, to give you my own answer, I do think the older patients are the area where there's a big advantage, because if you see an older patient with graft versus host disease, they fail miserably.
I don't agree.
And I'll show you some data tomorrow, but you know, I have plenty of patients who are over 70 with haplocord who are doing well without graft versus host disease, much better than they would have done with PTCY. So I think we've forgotten about that population because of the delay in neutrophil engraftment. And if we can, with one of these techniques, get around that, we may have a superior approach to PTCY.
If I may just add, I believe strongly that it's especially in the elderly population that it's more important to match, because the young ones, they will tolerate, you know, the more GVHD. Yeah. The older they get, they won't tolerate. So I believe if you're going to focus on the more elderly, well, first of all, you have to get rid of the non-myeloablative regimen that was used in the randomized trial. But I think in that patient population, I would really aim for a 6 out of 8 and try to avoid a 5 out of 8.
And I agree with you. And with one of your technologies or what I use, that can be done. We find more, you know, like you, we use smaller cords and find better matching cords.
And I also, I strongly believe that you need to find a niche for cord. And if you find a niche that you prove that it's really superior, then, you know, people will start doing it again, and they'll start doing it for more stuff. And I think second transplant is just, it's an easy group to, you know, MRD positive is great, but you only know that right before transplant. So you have to kind of be ready for like every eventuality at that point. So for me, second transplant is the easiest group that you could apply this to.
Thank you. Great discussion.
Yeah, there are currently different expansion platforms. There is the Dilanobicel, Omidubicel, UM171, SR1. Have you ever thought of the possibility of using combined expansion platforms, like combining 2 or maybe 3 of those different molecules? Would that be worth exploring? Or not really?
If I may just, well, go.
We looked at Notch and all of the combinations. We didn't find, well, this was a number of years ago though, so I will say, I think we even looked at Notch and UM and Notch and SR1 and no, I think we actually tried nicotinamide too. We didn't find anything that was uniquely different to suggest the combination genetic
Because they
better.
work through different molecular mechanisms.
Right, right.
So there is no synergism or something like that.
I mean, there could be.
Yeah.
But
I know in the mice, I know that they tested UM1 with SR1, and it seemed to be, slightly better. But I also know that they're looking at improving UM171 by, changing some things around to make it even better, So.
Okay. Thank you.
Juliet.
A lot to talk about, fabulous session, and we could probably talk all afternoon. But I think a couple of things. I don't think that we necessarily need to say out of all of what we're all each investigating, which one's the best yet, provided that all of us keep working in the field and just keep cracking away at sort of putting our roots down and trying to keep going and then sort of liven up the field and then sort of make a comeback, essentially. And I completely agree that we have to sort of focus on sort of niche, sort of target indications. And I do think the MRD is one to go after because of the fact that with the adult donor results, they're just terrible for MRD. So I think that's a unique opportunity. And from that standpoint, I'm going to go back to this HLA match thing for Sandra, because of the fact that I completely agree with Cohen, the older patients are not going to tolerate GVHD, but I'm wondering, Sandra, whether or not you would consider for the younger patients where you're really worried about relapse, whether or not you would actually preferentially select a bigger unit that is more mismatched and then apply your expansion technology. So having a bigger unit going in may help in terms of the sort of total fold output. You might be able to bring down your time to ANC even by maybe 5 days, which might be nice. And you may actually do even better with relapse. Like, is it that your product is actually able to mediate more GVL and therefore compensating for the fact that you're using units with less mismatch, meaning better matched units? Because we've taken a different approach. We're actually preferentially selecting high quality units with a high CD34 dose and low match grade. And that's probably, and 2 units, unmanipulated, so it's easy. From the standpoint of just, you just grab the graft and bung it in. And our relapse rates are very low. So you get what I mean?
The second trial we did was exactly that. We aimed for 5 out of 8s. And I think, sorry?
Or lower.
They're practically all 5 out of 8s in my second trial because they were such high-risk patients. And it's true, the young patients, they tolerate, if they get grade 3 to 4 GVHD, it lasts a few days, they respond to steroids and paf, you're done. But the older patients, it tends to stick. And then when you have those steroids, that's when the viruses come in and you've lost the battle.
Yeah, I think that it's got a lot easier since letermovir because of the fact that the CMV's just gone, and so we're not managing patients.
But I haven't
with
had
GVHD.
problems with CMV, but I'm just thinking all the other viruses, adeno and, I find the old, past 30, 40, they don't tolerate much. They'll tolerate grade 2, no problem. But more than that, I find they don't, and I'm not sure. I don't think I have enough patients and I don't have enough follow-up yet to see if the 5 out of 8s really, do they have less relapse than the 6 out of 8s, The question is it worth that difference? And what I get from the transplant community, the transplanters, they want an easy transplant. If overall survival is the same, they prefer the patient getting a relapse than getting bad GVHD. That's my take on, the transplant community.
Yeah, we need to work on that. But yeah, no, I get your point. You're absolutely right, except for the fact that if I was the patient, I'd take GVH over relapse. Because we've got letermovir, we've got Jakafi, and we have a lot of GVH because we're using really mismatched double unit grafts. And our recent transplant-related mortality has been 0
And
But-
doctors hate to round on those patients that have diarrhea that never ends.
Well, sure, but most of them, yeah, no, I get your point. And it's because we're probably used to sort of like intervening, and we have a little drill like boom, 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 and so we don't let them explode. You're absolutely right. If you didn't have the sort of things in place to look after those patients, and you let them explode, and you think, oh, I wonder why they're pouring sort of 4 liters of diarrhea. Indeed, everyone would agree you've lost the game completely.
Yeah.
But anyway, fantastic session.
I agree. It was a great session. I have a couple questions, but I just want to comment on a couple things from Cohen and what you were asking about with combination of. I think there's a lot of considerations that we're not talking about here that are somewhat out of our control, and I am very excited to see what happens when omidubicel gets approved, because I assume it will. I think that's going to be very telling as to how the field will change, and I think everyone here hopes that it'll make a difference. I do think we do need to make things easy. I don't know how much is this going to cost. How is this going to affect what the transplant physicians actually choose to do? I think these are all very important considerations to make. I think the other thing is, based on the study, the randomized study that we did, that showed really no difference between both of the arms, right? It's not that the expanded cells didn't provide rapid, early, low-level engraftment, right? It didn't reach the level of 500. But we were really after trying to make something accessible and easy, right? Not delaying things. So we really took a different approach. We're not matching the expanded cells. So I almost think it's a totally separate approach from what you guys are doing with the matched graft. But I do think there's a lot that we're not discussing around cost especially, and delaying a patient who needs a transplant and what the physicians will decide. So the questions I had, though, back to the talks, I'm gonna try to remember. So the data you presented, Mitch, on the T cell recovery and the early T cell recovery, I think it was CD4, was it CD4, on day 7 and day 14?
Yeah.
That's incredibly fascinating to me too. Like I can tell you're trying to figure out what is this. It makes zero sense to me. I'm just going to tell you,
Yeah,
because
exactly.
that is not coming from anything that even touched the nicotine, right? It's the negative fraction, which has a third less, or you gave a third of the T cells.
Yeah,
So
30%, yeah.
it inherently makes no sense to me.
No.
So I'm curious though, what the absolute numbers of, like, are we talking about a CD3 count of 50 that data is from? Or is there do you know what I mean? Is there actually some level of T cell engraftment there that you can hang your
Very
hat on?
low. I have to look at the figure again to give you the units. It was something like, in well below 100, as
so
you'd
how-
expect.
Yeah.
So maybe it's an artifact. I don't know. But
Yeah,
it doesn't make any sense. You're exactly right. These are not stem cell derived. These are obviously transferred T cells that seem to be proliferating earlier. I'm assuming they're donor derived. I mean, most of them they all got ablative preps.
Do you think there's something in the expanded graft that is immune modulatory, so that those T cells are actually free to
That's what
expand,
Paul would say. Paul posed that question as perhaps there's a milieu that is more conducive to activation right away. That perhaps the expanded product, which is not as well characterized as the UM171 graft is. So this is the crux of the question. I mean, your product didn't provide a difference in the primary endpoint, which was, if I recall, infections, but it did something to
Or AML.
Oh, you mean in AML?
for
infections,
AML,
yeah.
but it did something to the recurrence rate, right? That's what
It
you're
absolutely
signaling.
did.
Complete
yeah.
response.
So that suggests that these cord blood-derived progenitors, not T cells, right? There's no T cells in your product.
No, and we think that's the
so-
pooled donor aspect, though.
What's that?
We think that's the pooled donor aspect of it, that it's an antigen load that you're giving, and the product contains a lot of APCs. So we
Right,
think this is very similar
it's
to
a
what we're gonna hear later.
non-lymphoid
Activation.
modulation of the host environment
Right.
that's doing something, and maybe that's the answer. I think that's the only thing we can pose, is that it's changing the milieu.
Yeah, it's fascinating. And then my question for, I guess, both of you, and if you mentioned this, I'm sorry, it was all going so fast. Can you speak a little bit about how you looked at, you both mentioned TNC, and Sandra, you were talking about how you gained access to X number more units because of the TNC. What about the CD34? Do you have a what's your limit for the graft that you choose for CD34?
So on paper, it's 0.5 CD34 times 10 to the 5th per kilo. That's the minimum.
In the freezer?
Yeah.
That for
that I
selection.
select. So,
To select,
so
for
the
select.
number the cord gives you, and for the TNC, I believe it's 1.5
Okay.
minimum.
And then do you have is there a level that you?
There's a minimum total CD34 dose
Yep.
not dose, but content in the graft. I'm trying to remember, Stuart, you can maybe remind me what that is, but what is it? 8 times 10 to the 6th CD34s and a TNC minimum of, it's a TNC total minimum of 1.8, I think.
And did you guys did you have trouble finding grafts that contained that for some patients?
It wasn't, we've done about 28, 30 at Duke, and I would say yes, the answer is yes. Not very often, but the answer is yes. Particularly when you have an alloimmunized patient who you have to really
Right.
sort of whittle down the
Right.
selection.
Right. Thank you.
I have a question, a similar question as Colleen, because we noticed that when cells were sent over to Gamida, that the cell counts of the units extremely high. Not only that you have 8 to 10 to 6 CD34 or even higher, but these are also units who have naturally a higher T cell count, TNC count, and everything. And so my question is, you do AC 133 selection first with a quite good recovery, I think.
Yeah.
And then you treat these cells with nicotinamide, which is it a de-acylating agent for the epigenetic? Is it de-acylating or is it acetylating? It's de-acetylating.
You're asking really good questions. Gamida is one of the sponsors of the of the meeting, and there's people here. They developed it, and they can answer those questions.
But this goes into the direction whether maybe with a deacetylation you induce also different progenitors besides the CD34. You expand due to the deacetylation, if this is the mechanism, but I don't know.
Yeah, I think, really important questions, and I don't know if the answers are known, but important.
Hi, Mitch. A practical question. Assuming we're a few months from approval for omidubicel, what should cord blood banks, for example, do? Ship units to Israel and then they get infused at Duke, for example?
Yeah, the NMDP is going to facilitate that, but that's exactly how it was done in the trials, and that's how Gamida conceives of it after approval. It will be, and their manufacturing facility is now operational in Jerusalem, and the units will be sent there as opposed to a contract manufacturing facility that was used for the study. And then they will be sent from their facility to the transplant center.
Idea of price?
I hope it's not too much, because that's going to be a problem if it's too much, yeah.
Thank you.
But I don't know.
There is assurance issues in the United States. Don't forget that. It's an important step that needs to be taken into consideration. I know that Gamida is working with many groups, finances, because it's more complex than just the cost of the unit. I have maybe one comment for Sandra. And so I know that you are looking at EBMT cohort. My recommendation would be to wait. If you can, just getting more patient, because I was surprised actually to not see any difference in terms of relapse when you compare to both groups. Because I think for what you said and for what I'm expecting as well from your product, that you should enhance some GVL effect. And I do think that you do not see that difference because really you didn't have enough patients in your cohort.
I'm not sure we have enough patients, and also I will say this: the high-risk patients, for example, I had a patient, it was really palliative care or UM171. He was an ALL who had relapsed after an allo and who was refractory to chemotherapy. They couldn't find anybody to match that, So it's hard sometimes when you're taking such horrible patients that would probably not even be transplanted to actually match them.
But that's why you do a matched paired, but I think you do need more patients. Because I think you want to see some difference, yes, but I think, again, meaningful today is relapse. It's because we need to prove ourselves that we are extremely better than others. Just being a little bit better, I don't think it's enough. So,
as just a final comment, we have more patients coming, right? There was more done at the Hutch, and so that will be forthcoming. Well, this is why it's so great to be back in person, and so much better than looking at a monitor. So thank you so much for a great session.